All right, welcome everybody to our June webinar of the Food Allergy Institute. I'm Dr. Randhawa. I'm the founder and CEO of the Food Allergy Institute. We want to welcome everyone. It's going to be, I think, a great conversation. I'm particularly excited about today's topic because it's part of our organization that we don't, honestly, I think, talk about as much publicly, and we should. Our care model is unique. You'll learn really a whole lot about it. I think you'll be thoroughly impressed. I've worked in so many facets of healthcare, from large university systems to large hospital systems, and I've never seen this type of care model applied to a single medical condition. And then you add to that what we do here at FAI, which is reach remission for every single patient, that level of food freedom. I think this combination of this conversation today is going to be really, really great. So before we kick off our discussion today, we're going to start off with a quick video, really talking about what the goal is for everybody in this medical condition with what we deal with here at FAI, and that is remission. And it's best to hear it from the patients themselves.
How long have you been in remission for?
2 weeks.
I think 4 years.
Well, I finished it last year when I was 9, so that's 4 years.
I've been in remission for 6 years.
6 years.
I've been in remission since around August of last year. So this is about my first year of remission.
What's your favorite food now?
Definitely Reese's peanut butter cups. Donuts.
Pizza, definitely, hands down.
Almost everything.
Almost
honestly.
everything?
Most of my favorite foods I wasn't able to eat before. Cake, donuts, cupcakes.
What does food freedom mean to you?
It means that I'm able to eat whatever I want, whenever I want it, and it's so important to me because all of my favorite snacks I wouldn't be able to eat today, and all my favorite foods, I couldn't eat them, so I can eat things without checking.
Food freedom means to me everything, that I do no longer have to worry about his safety, that he can eat whatever he wants, whenever he wants, and he is independent, and we are good to go. Spontaneous life.
This plague changed my life a lot. Like, I used to never be able to eat certain stuff, but now I can, and I'm really thankful for the people who helped me get to where I am now.
And so again, welcome. I'm the founder and CEO of this organization. I've dedicated 20 years of my life to the space of food anaphylaxis. As you know, I will say, this organization really is a reflection of my background and my work. I'm a transplant immunologist. I hold multiple board certifications. I spend, even to this day, a good portion of my time in the intensive care unit. And dealing with the most complex cases, I really utilized an entirely unique angle on applied math, data science, then very early machine learning and AI. This is going back, again, almost 15, 16 years before it was ever popular, and building up this system that can forecast and predict risk. It can forecast and predict how a child can actually utilize biosimilar protein immunotherapy and actually achieve a state of remission where they can actually consume these foods that once could cause severe life-threatening reactions openly and without limitation. Those are the key elements of this organization. These are what we work toward on every single patient who comes here, whether they're coming here locally or they're coming here from around the world. These are the stories that hit every single day. We have about 2 patients hitting a remission every single day. That's a number that's pretty remarkable. And I think what we are really working toward is shifting the standard of care. All too often, what I hear out there amongst the medical community and amongst the patient community is they hear it's not possible. It's just not possible to get to remission. It's not possible to have a 99% success rate. I think you'll understand as you hear the presentation here today how it does become possible. We're doing this work now under the most extreme forms of regulation, and we've been doing this now for 20 years, which I think will reflect that a shift in the standard of the care is necessary for food allergies. And indeed, being a remission patient in TIP is actually a safer and, in fact, a healthier state of life than living with food allergies. So today we're going to also be bringing on board Mia Loftus, who's been with our organization for almost 6 years now. In fact, I think she's been here a little longer than that because she came here earlier for a brief stint. She's from Philadelphia. I'm going to hand off to her briefly. And I think it's important to hear what our clinical model looks like on the side that the people don't see. And this is the concept here is that we're not only looking at data in the typical form, we're looking at data on an ongoing basis, and it's being managed behind the scenes. So this is including when individuals don't even have medical issues of any kind. This is an ongoing process of data management, and this escalation process really separates us from any other medical enterprise out there.
All right. Hi, everyone. I'm really excited to be joining you today. As Dr. Randhawa said, my name's Mia Loftus. I'm a certified pediatric nurse practitioner, and I've been with the Food Allergy Institute since 2019. I come from the Philadelphia area, so my undergraduate degree's from University of Pennsylvania and my graduate degree there as well. And formerly, I was a nurse at CHOP, so shout out to all my Philly people out there. One thing I noticed from working in the hospital is that frequently, as Dr. Randhawa mentioned, is we're really trying to just stop conditions from getting worse and not really addressing the root cause of it. So when becoming a provider, I really wanted to shift that and look to get into a role where we're preventing things before they happen. So being in this space in food allergy, I've just really fallen in love with because I really have not found in medicine somewhere else where you can make this big of a difference without the use of heavy medications and really see a change in a relatively short period of time. When you think of someone's lifetime and you dedicate a couple years to this program, the trajectory of your child's life really does change. So I'm excited to be joining you all here today to talk about it more.
Awesome. Thanks, Mia. Our clinical model is built on a lot of infrastructure. I think the one message that I always try to get out there is if you've not been here, you've not seen how the Food Allergy Institute operates, the message is very simple. It's not a doctor's office. It's not an allergist's office. This is a large enterprise. You have hundreds of employees across about 125,000 square feet of space that make this system work, and make sure that this is going to give every patient the safest, most effective form of treatment over the period of time that they're forecasted. Our team is supported by literally everything you see here on this circular approach. We have molecular science, research science in a molecular science laboratory, all affiliated inside our organization. We have our applied math and AI systems that directly feed the next level of ideas into what we're going to do next. We also have a diagnostics lab that is the only level 3 high complexity lab in the world when it comes to food allergy. We are the largest food allergy diagnostics lab in the world at this time, and we maintain the highest level of accreditations. We also have our own internal billing system, and that means a billing department to try to make the patient experience complete and better. And I think one of our most popular things is our food lab and, the different gummy products and tart products and, in fact, newer products that are coming out to try to make the process of treating food allergies here in TIP so much easier. And then key to all of this comprehensive care are the people. We have, I just think, the best folks in the system. Mia's certainly been here for a long time, is a great example of that. We hire people who are mission-centric, who want to see every child get to the finish line. They understand our system well. They're trained extensively, and ultimately, it is the people, whether it's on the clinical side, the customer service side, our finance side. All areas really are working together to make sure you and your family get the best care possible. Our laboratory, and it's, I think, important to mention this, our laboratory is a fully intertwined laboratory, which means that the testing that we run, and again, we run a large number of tests that are fully proprietary, meaning that there are tests that we run, we have done the discovery on, and we have to go through the process of getting those tests out to our patients first and then out to the general public. I've been doing this work now for the better part of 20 years. And in fact, many of the specific component tests that are even available commercially that you may have had tested on your children were actually developed through our system, either through our laboratories, through our biobank. And so we have that effort as well to get things out to the general public. But what we really try to target is the right type of diagnostics that can create the right type of data so that we can actually use our AI and machine learning systems to forecast it for your child. That's very important. As you know much about AI today, you know that you worry about AI not getting it right. Well, we don't worry about that here because our AI operates on extremely good data that comes from extremely good laboratory function. And just to again add, this type of lab with the quality of work that it does and the reproducibility of results, it cannot be matched, whether it's Quest, LabCorp, or even university-based labs. It simply cannot be matched, and that's why we've achieved that level 3 high complexity status under multiple regulatory agencies. Our AI model and our machine learning models have been built here for now the better part of 15 or 16 years. It's important to recognize that AI is not something that's easy to build out. It's not something that you can get to a commercial standard or commercial level. We've done that. Not only does our AI create an accurate diagnosis, the AI can actually forecast a therapeutic model towards remission and beyond. I can tell you as of today, if you look at all of modern medicine across cancer research to other types of medical specialties, as far as AI has gone, it is generally around the area of diagnoses. And even there, it's not very accurate, and it's in the early stages. We've taken this to the next level. Again, when your child comes in, they'll undergo a full battery of tests, hundreds of different analytes, different tests. That is entered into a large-scale AI system that will produce a snapshot of risk, much like you see here on our screen, and that will then generate the actual treatment process, going through phases and steps of pre-treatment, conditioning, tolerance induction, and then eventually remission. The accuracy of it is high. Are we absolutely perfect? No, but our accuracy is in the high 90% range, and this is work we've published and has been published across peer review as well. So, key to our clinical team, again, is the diversity in what we have available. So our organization not only has a number of specialists, these include allergists, pulmonologists, affiliated GI doctors, and so forth. But really, it's the diversity of what their experience is as well. So, for example, we take care of all levels of cases. You can come in with any different type of medical condition. It could be a mental health condition, it could be an autoimmune condition, it could be even a cancer diagnosis, something of that seriousness. And we will find a way to manage those cases. So we do this because we are built across a multidisciplinary structure, and you'll get a sense of how this kind of was organized in our care team model. And Mia will also jump in on this as well and explain some of those steps and how we actually take very complex cases, go through an entire process to make sure that we understand what's going on, how it'll affect your child's TIP journey, and how it can make sure that you still get to the finish line and reach remission.
Great.
So in our clinical care team, the continuity of care is really, I think, one of the most key components. If you look at how we're not organized like a typical medical office, right? You may go to see a general doctor or you see an allergist. You may see that person every 3, 6 months or 12 months. You may see some different staff members, and sometimes the continuity of that care is going to be disconnected. Here, despite seeing a very large team of individuals, the continuity is actually very well connected because it's connected both centrally and remotely. What that means is we have central information that's constantly being run in our command center, and then we have the information that's being delivered at the level of the pod. So which means at the clinical sites, you're actually seeing a provider who is fully aware of your case, knows all the details of what's going on up until that minute. And that conversation then becomes so much easier and so much more accurate and controlled. So this allows our patients to come in. They come in roughly 4 to 6 times a year for different challenges. Remember that 99% of this program is done at home. So imagine that we have to actually capture data that's at home and everything that's going on with daily home dosing. And then we have to capture the data that's occurring while you're actually here for your food challenges to make sure that you pass each of those steps and eventually reach a state of remission. And again, I think I'm very proud to say that in 2024, just to give you an idea of how many food challenges were carried out amongst our system, the number is pretty outstanding. Over 50,000 food challenges and food challenge introductions occurred with a total reaction rate less than 1%. Just to give you maybe some a caveat on that. If you were to go to some of the largest university systems out there, how many food challenges do those large systems do on a given month? They're generally doing less than 20 to 30 challenges a month. So in a given year, they'll be lucky to reach a number of like 300 to 400 challenges. And we're crossing 50,000 plus challenges. And this is done all under supervision. Our reaction data is actually published online, and again, all under regulation, which again is something that we're very, very proud of. So.
And I think it's great to note too, like our nurse practitioners and physician's assistants truly are experts in running these challenge appointments. As we mentioned before, the training that they undergo, but then just every day, that is what they are doing, is running these food challenges. So they are really there to partner with you. And that pod relationship that we talked about is really important, from the clinical side to, the other softer touch things as well, that your child lets us know they have a big soccer game coming up and something else happening. We see you again in 8 weeks and we follow up on how all your foods went, but also how life is going as well, which is important as we celebrate and work through all these milestones that come with treatment. So to touch a little more on our clinical care team and ongoing collaboration, our care team is going to be working with all of your existing specialists, and we may even bring in some other specialists. It's really important that your health is optimized while you're going through treatment here. So if there is anything that is lingering, your child has a cough, they have asthma, that is okay. You don't really have to follow up on it too frequently. When you come into the program here, we really need to ensure that everything is under control and that there doesn't have to be any other treatment that needs to happen before going into TIP. So we are really getting your child into their best health before even starting, and we want that to continue throughout TIP. So in order to do that, we are going to work through our on-call team. When you have that visit in the office, it doesn't stop there. We want to continue to reach out to your primary care experts, your pulmonologists, gastroenterologists, and we do that through our command center and through your leads within the pod as well. So you'll receive that point person, and we really will follow up on anything that needs further digging into. If there's something that is different about your case or about your child, we'll make sure we have all the information about that before going forward. And as Dr. Randhawa mentioned, we have a lot of data coming in from ourselves to the research, the diagnostic team, so that those touch points throughout treatment are really going to help continue to drive our direction of treatment. You have your treatment plan that you're given in the beginning, and then we're going to follow up with this ongoing data to ensure we're still on track and progressing properly. So if something comes up in the middle of treatment, new diagnosis outside of TIP, that doesn't have to put everything on hold. That doesn't have to stop your progression. We really integrate that into our plan and can work to continue forward. If you have anything else to say on that, Dr. Randhawa?
Yeah, no, I just echo your main point, which is that we are not looking to see symptoms or see reactions. We're going to proactively utilize data to prevent those things from happening. And that's really an entirely different way of looking at healthcare. And again, we will see some symptoms, reactions do happen, again, albeit, small numbers. But then we have a team here that's absolutely available and ready to take care of things. So, but I'll let Mia talk about how the command center operates.
Yeah, so our command center, as Dr. Randhawa mentioned, there are reactions that do happen, and we ensure that you are prepared to handle those. A lot of the dosing goes on at home. 90% of our program is happening every day at home and usually symptom-free. But in the event that there are symptoms, we are here for you in multiple ways. So we have the on-call reaction line, 24/7, holidays, weekends, anything. You can get a hold of someone when you call that line. So if something happens that's related to TIP or not related to TIP, you had a food exposure that you have not treated yet, and you need assistance in that moment. If you want to know what to do, we are here for you. So we walk through accidental exposures, reactions related to TIP, and then we bring that information back. We'll help stabilize you in the moment, but then we'll look from there. What does this mean for your plan, your program, and how can we adjust forward? So our team in the command center, we have a senior logistics MD who is very adept at managing these reactions and also using the data and AI that we have and bringing those together to make decisions for moving forward in the moment. And then our command center leads, myself and another nurse practitioner, are here all during the week. So we really help with continuity. And when you need to get on the phone and talk through something, we are here for you guys, as well as our other providers that rotate through. You'll see them in clinic, and occasionally you'll see them on call as well. So they have that experience of being in clinic and also being on this end of things as well. So just really want to highlight here is we are here for you, and we are here to support you in any way that you need throughout treatment, whether it's related to TIP, related to another diagnosis, or just related to life in general. A lot of other things that come up are challenges with life. We have another family member that passed away and you need to make adjustments based on that. We are going to support you through all of that. And then just so our command center, how we work is if there is a issue that comes up, a reaction, symptoms, a new diagnosis, we operate similar to a hospital. I'm not sure if you guys are familiar with that, but we have daily rounds where we bring these cases and we discuss them with our lead logistics MD. And at that time, we'll look at making an adjusted plan. So we do not let issues or symptoms, reactions linger. Really within 24 hours, we are giving you updated direction and plan moving forward. So I think that is something that is unique about our system here. Is I've heard from other families when they've done allergy treatment in the past is one reaction comes up and then that's the end of that treatment for them. That's not the case here. We are able to use data to really predict what is going to be the best path forward, and we will always look to find a path forward for you. And again, we use integrated care. So if we are seeing that your child has maybe an underlying condition that might need more diagnostics before we move forward with TIP, we have GI specialists that we can refer to, pulmonary specialists, and we have them locally, but because of the work that we do across the country, we really have connections with lots of different specialists across the country as well. And we are getting on the phone with these specialists, and we don't want care to happen in a silo. We all work collaboratively for TIP and other diagnoses as well.
And maybe I just add to that, Mia, it's a really important perspective to take away, because if you ever had experience in the healthcare system, you know that this is not how it's done anywhere else. If you have a medical condition, let's say it's allergy related, and you need some help in an urgent way, they essentially tell you to go to the ER, call 911, go to the ER. That is, the way the system works in this country and really in most countries. We believe that providing a dedicated team 24/7 with continuous monitoring over each case, utilizing high resolution data, this provides not only the best technical care for the patient, the family, this actually stops the derailment of treatment, right? And that's really the problem with our larger healthcare system. Treatment starts in certain ways, and then something happens, referrals needed, a different person needs to evaluate the case, and all of a sudden, 6 months have gone by, and a medical case has actually been derailed. And so we've worked very hard to make sure that never happens in this organization. And again, I think this is just a standalone aspect of what we do compared to the rest of healthcare.
All right. And just to touch on, we talked about the support that we have, you being able to call in and get that support 24/7. But it's really important. You are our biggest partners in care in your tip journey. So one of the things that we do at your earliest visit is talk through and prepare you. If there were ever to be a reaction, what would you do? We have every patient that is given a personalized scenario plan with specific medication doses. And those doses, we have you prepare. You will have your kit ready with scenario 1, 2, and 3. And depending on the exposure and the symptoms that we're seeing, we will be able to utilize those over the phone with you. So it really is as if we are right there with you in the event of a reaction. Obviously, we never want that to happen, but in the event that it does, families really do report that they feel prepared. We check these medications off every time you come in. You'll get bothered by us saying, bring them in, let me take it out, let me check the expiration date. Okay, yep, you're all good. Families are like, oh, you did this last time. You did. We are going to do it every single time because we want you to feel the confidence that you can handle anything.
All right. And so we will open this webinar, as we always do, to the general audience and answer any questions you may have. But certain questions were submitted ahead of time, so we'd like to try and take those questions on first. I'll take on some, and Mia certainly will take on some specific ones as well. First question, are there any cases that TIP cannot treat? The short answer is no. Again, what do we treat here? We treat food anaphylaxis. So if you or your child has a diagnosis of food anaphylaxis, you carry an EpiPen because of it, you are the right kind of patient for the Tolerance Induction Program. If you have food sensitivities and you're not sure you are anaphylactic or you think you're developing anaphylactic allergies, we have some of those patients come in here and we're happy to see them and get them diagnosed accurately. Many of them do have anaphylactic risk and we'll go ahead and treat them. Some of them don't, and at least they get the information they need diagnostically and they move forward. We treat all levels and all levels of complexity. So you can imagine the typical cases that we see here are those who have very high numbers. So, kind of numbers at 100 range, the numbers that tend to be very scary, frankly. We also have patients who come here who've had severe reactions, multiple EpiPens, hospitalizations, ICU stays, and things of that nature. We also treat all the comorbid type cases. That means severe asthma, moderate asthma, patients who have eczema, severe skin disease, EOE, eosinophilic esophagitis, and more. And so hopefully, as you now understand how our complex care model looks and how we operate, we can kind of decipher and really take apart the complexity of a case and really build a path forward for all patients, which I think just makes a huge difference. Mia, you want to take number 2?
Sure, yes. Does provider support continue into remission? Absolutely. So that's the short answer to it, but we have continued remission testing annually that patients come in for that we will be able to get an updated look at how your body is responding to everything and make decisions around if we can further space foods out. When you reach remission initially, we have you on a weekly basis of your food. But then as you move forward into remission, your body continues to frequently need less and less frequent exposures. So we will continue to support you that way, but also you still have access to the command center. So every time you have an issue, question, want to update us on something else medically, we are here for you. So absolutely, you still have that support into remission.
Thank you. Number 3 is, how does the food challenge at my local allergist office differ from what we do here at FAI? Well, in short, again, it's totally different. The local allergist who's conducting a food challenge, first of all, unfortunately, there's not a lot of allergists who want to participate in food allergy. Large surveys done nationally show that about 1 in 5 allergists, which is not a very high percentage, are willing to do a food challenge in their office. And even those who do often are doing a small number of food challenges per month or per year. So they're doing it generally to see if a patient is actually not allergic to a food. So maybe a skin test was borderline positive and they'll go ahead and conduct a food challenge. The way they do their food challenges is also, again, vastly different than what we try to achieve. They will generally utilize a room in their office. They will not have the patient monitored in any significant fashion. They will then go ahead and have a patient consume some variable amount of a food. And, what amount should a food challenge be is unfortunately not standardized. It is very standardized here. We know exactly how much to challenge patients to prove that they're actually free and clear of their previous anaphylactic state. And so there's quite a few differences. And so often in the local allergist office, you'll kind of just do a 30-minute visit. They'll give you the food protein. If you happen to have no symptoms, they'll say, great, you passed, now you're good. And that's kind of where the differences now really start to show, because here at FAI, when you come in for your first visit to us after your launch, which means we have all your diagnostic data back, we'll be doing multiple food challenges outright to foods that your child is likely not eaten at all. And that comes from confidence of knowing that our data and our AI system is accurate. It's often one of those times where parents are kind of nervous and they're like, oh, wow, what are we doing here? How can we just do outright challenges? But when we do our outright challenges, and then, of course, our subsequent challenges as part of TIP treatment, we have all of our patients hooked up to full cardiorespiratory monitoring and beyond. So as somebody who spends a lot of time in the ICU, I wanted that level of security around every single case. And not only do we conduct the food challenges in a highly standardized way, we'll make sure that the amount of protein is a clearance amount of protein. And then after every challenge, we conduct a stress test. And the stress test is critical because, as many of you know, if your child has a reaction to a food, it often only shows itself under a period or under a time of stress. And so we do exercise stress testing. We push the patients pretty aggressively to high heart rates and high blood pressures. And then, of course, we evaluate the patient with all of that cardiorespiratory monitoring and further data to make sure that they're free and clear. So, yeah, there's some pretty dramatic differences between the way we do things and general allergists. And I'd say one last point is that we do this for safety. We want to make sure that when you pass a challenge and you got to drive home, or you pass a challenge and you go on an airplane to fly home, that there's not going to be any concerns, when you're done with that challenge. Question number 4 is, what's the difference between bite safe or bite safety and food freedom, or what we call remission? And this is a great question, because I think in the world of food allergy, if you have a child or you yourself have food anaphylaxis, you've heard more and more about this concept of being bite safe, this opportunity to go through OIT, which is oral immunotherapy, and hopefully reach a point where you can kind of consume some amount of peanut or something else, and then you're, quote, bite safe. Xolair, which is an injectable, similarly tried to test this concept of bite safety. And my argument against this concept of bite safety is that you not only want to understand what bite safe means, you want to understand what cross-contamination risk is defined as. And we've done that work now for 20 years. We've collected so much data based on historical symptoms people have had, the amount of protein they've had, and different types of reactions they've had, to really understand and define what amount of protein or food protein will trigger what type of reaction. Bite safety, as was even seen in the published study from Xolair for food allergy, was numbers. These were numbers that were all over the place, depending on which food you're talking about. And then it showed that individuals could actually pass a certain amount of OIT or a certain amount of Xolair and then continue to fail the bite safety process when they got exposed later on down the road. So that's the problem with that concept of bite safety. What do we do here? At FAI, we look at the concept of remission, right? So number one, end of our program, we're not looking to just have you maintain a small amount of a certain amount of this food. We want you to consume this food like a non-allergic person. You all know non-allergic people. So if you're non-allergic and you want to eat peanuts, you don't eat a half a peanut or one peanut. You want to be able to consume a full peanut butter and jelly sandwich. You want to be able to have, pad thai, which has, a large amount of peanuts in a single serving. You want to be able to, if you're allergic to dairy, be able to drink an entire glass of milk or more. So our final food challenges in the end phase of our food freedom visit are significant challenges. They're equivalent to 10 ounces of milk in a single sitting. They're equivalent to 60 to 75 peanuts in a single sitting. And those numbers sound very daunting when you're, sitting across the screen from me right now. But the reality is we've done this now for thousands upon thousands of patients. It's important because when you hit that level of remission, we're not worried about you having a reaction afterwards. We're not worried about you going to any restaurant, any food service, any social engagement, and having a symptom again. And in fact, we want to change your perspective on food and change your perspective on these allergenic foods and actually consume them like a non-allergic person. Question number 5, what does at-home dosing look like? And I'll hand this one off to Mia.
Sure. So at-home dosing, there are 2 major parts of the dosing that happens at home through TIP. As we mentioned, there are challenges that happen in the beginning that are outright challenges. So after a food is challenged in TIP, we use that food as a maintenance food. That maintenance food is consumed in the beginning every morning. So we do those maintenance foods every morning, and these foods are used to condition for your more allergic foods coming up. So the biosimilar proteins in these foods are going to help you down the line for your more allergic foods. So in the beginning, it is going to feel like, okay, I'm getting a large amount of maintenance foods to eat every day. It's not going to be forever that you have those, but you will have foods you have in the morning. And then in the evening time, after you have introduced a food in clinic, you go home with a dosing cycle. So these foods are foods that we have not yet challenged. We've only done a small introduction in clinic, and you'll be dosing increasing doses each week at home. And then you'll return to clinic and do the food challenge with the exercise afterwards in order to move those foods to maintenance. So that's kind of the life cycle of a food in our program. If you are thinking about, okay, I've got this many foods, wow, pretty quickly I'm going to have 10 foods that my child is eating in the morning. That will again be for a period of time, and then we will get updated data on your child. And if we have seen the conditioning benefit that we need from some of these foods, we'll be able to space them out to less frequently. So pretty quickly into the program, you won't be having them every morning. They will be able to move to 3 times a week or a weekly basis. And that pattern continues on even as we approach your highest allergens. As we mentioned before, in remission, you get to that once weekly dosing cycle of it. So in the grand scheme of things, that making your child eat something every day is really heavy early on in TIP, but towards the end, you really just are getting to these once weekly requirements, which is a good trade-off for the level of care that you have to take during avoidance before treatment.
Yeah, thanks, Mia. I would even just add to that. I know that sounds like a lot of information, but we have really all the technology and all the education at your fingertips on how to start this program, how to do the maintenance foods and treatment foods. And, the benefit of this type of system is that, again, well over 90% of this program is actually done at home. Essentially all of OIT is done in a physician's office. You have to go in once a week and sit there for 6 hours and things of that nature. Our system allows you to dose escalate with a data-driven model at home to reach pretty high doses of protein, and then come back here and we challenge pretty large clearance amounts of protein. And the beauty of this system is that we're treating all foods, as far as the TIP process is concerned, simultaneously. You will go 3 or 4 months, and all of a sudden your child's eating a food that you've seen them have an anaphylactic reaction to. And most parents are pretty surprised and often, sitting there in a state of awe of like, how are they consuming this food now openly? And then, of course, we just move on to the next food and the next food. And we're utilizing data this whole time, including repeat blood work, to go ahead and make sure that the process continues on safely until you reach remission.
And just to note too, Dr. Randhawa did mention our food lab earlier. So doses at home, when we start with doses that are less than teaspoon amounts, for example, for nuts, anything that is measured in a smaller amount, we will provide gelatin or tarts for you. That way you're not at home at a scale trying to figure out how much to give your child. Was this a little too much? Is it perfectly balanced? No, you have that confidence that you are getting those doses at that smaller amount already prepared for you.
Absolutely right. And our last question of submitted questions is, what is the success rate specifically among EOE patients? Again, for those who are not aware, EOE is eosinophilic esophagitis, condition that was really discovered in the 1990s, mainly in adults. Saw a presence of it in pediatric patients in the early 2000s. And it has a relatively high incidence rate in the general population of kids who happen to have reflux. So kids who have gastroesophageal reflux, there is a high percentage of them who kind of overlap to EOE. There is a very small subgroup of patients who have EOE and happen to be anaphylactic to foods. Those are the groups of patients that we treat. We have lots of experience with these patients. They're about 5% of our patient population, and we have the same success rate amongst them. Remember, every patient that comes in is actually assessed a certain type of snapshot, and the snapshot is based on a subgroup analysis of their data. So what that means is we don't treat every patient the same, right? Everything here is highly specific based on AI. And so our EOE patients actually undergo very unique treatment processes to make sure that they're safe, to make sure that their EOE is under control. It's actually one of the critical elements here. Their EOE must be in remission during treatment. And then once the patients actually hit Tolerance Induction Program based food freedom and remission, we're actually able to wean them off their EOE medications. And it roughly takes two to 3 years to wean them off medications. But really, the vast majority of them are able to wean off completely, exceptions being for some of the reflux-based medication. So with that said, we're going to open this up to questions. Give us 1 second here while we set up. As we've done in the past, we're going to ask you to raise your hand, and I will call to unmute you. If you don't mind, it'd be nice to maybe not have you, maybe you can turn your camera on, but at the very least, tell us your name, where you're from. How are you doing, Alex?
I'm good. How are you, Dr. Ronald? My name's Alex. I live in Ann Arbor, Michigan, and I'm 24 and I have a severe dairy allergy. And I did have some questions. I want to ask, what are the chances that you think that this will work for me, this program? How many dairy allergic individuals have successfully completed the program and are now consuming dairy, and at what age? That was my first.
We published really a standalone study last year in the top journal in allergy. It was the largest dairy allergy study ever conducted, just to give you an idea of the scope of what we're able to do here. As far as adults who have dairy allergy versus younger patients, the results are largely the same, to be honest with you. In fact, I actually would say that if individuals who are adults who have a singular dairy allergy, meaning they're not allergic to anything else, their immune system is highly focused and highly trainable, where the TIP process and biosimilar protein immunotherapy is highly effective. So we have a 99% success rate. That success rate holds for all patients.
Mm-hmm. Where's the proof that it works for 99% of people? Like, where are your studies that's true?
We can certainly, number one, they're on our website. They're also on PubMed. And then I would also want to really add a specific point here. Every single patient who comes into this program since its inception signs an IRB consent. That means they're part of the institutional review board and there's a reporting process. We've been under multiple IRBs since the inception of the program. That is a reporting process. The reporting process has to go up to the IRB and is under regulation to the FDA. So our data is pushed up out on a quarterly basis, and certainly the regulatory agencies are going to make sure we make sure our claims are accurate.
Okay. My other questions are about maintenance after completion. Like, what do I do to keep tolerance?
Right. So Yeah.
So
Great question. So maintenance for dairy specifically is the same goal for all other food proteins, meaning we're looking for 7 days of sustained unresponsiveness. So we want you to consume a certain amount of dairy day one, 7 days later, you consume the same dose. That year is usually 1 year. So 1 year of remission. And based on repeat data, we can often move that dosing to 2, 3, and 4 week cycles. So the next number of years, that's the maintenance. Dairy in particularly requires a set amount of protein. The proteins have to be reflective of your particular allergen risk profile. So you might have certain proteins that are higher risk than others, but generally speaking, patients are consuming what is the equivalent of about 10 ounces of uncooked cow's milk, although it's a specific form of it, on a weekly basis initially, and then it weans down after that.
So I'll be able to free eat after the completing this, basically like a free eat any dairy products.
Cheese, ice cream, any products, and yes.
Just if you have time for one more quick question, I don't know if you could answer this. Is it covered under my insurance, Blue Care Network? And I did speak with my insurance company on the phone, and they said I don't get any coverage for out of state care unless it's for urgent or like emergency care. Like, how much does it cost?
From a clinical billing standpoint, I'd probably refer you back to our enrollment team. That's a super specific question that I can't answer for your insurance, but we have a lot of out-of-state patients. I really encourage you to spend a few minutes talking to the team, and they'll give you some specifics that are very clear. Yeah, I mean, the program, again, for most patients is about 2 years. Depends on the total number of allergens you have. Obviously, if you have like 8, 9, 10 allergens, it's going to be a much longer program. If you have a relatively straightforward allergen, it can be even under 1 year. So the key point here is you have to get tested, and the data on the testing kind of predicts the length of the program.
Okay. Thank you very much. Appreciate it.
Yep, you got it. Thank you. All right. Next up is Preeti. Hello.
Hi, everyone. Yes, my name is Preeti. I'm from the Chicagoland area, and I have a son, he's almost 4, who has severe gluten, eggs, and unfortunately likely developed a soy allergy that he was able to tolerate before. My question is around once a child hits remission and then afterwards, let's say they're going through puberty, right? When they're going through puberty, hormones, things change. So I'm curious if you have any data on how puberty has affected those that have reached remission.
Yeah, that's a great question. We have lots of data on that. And I think it's important for everyone to recognize that when we do this comprehensive testing, this is testing that nobody else does, right? So it's really thorough. And you go through the Tolerance Induction Program. When you're done, we should have tackled every single class protein that could ever be problematic, right? So the argument here is that when you finish TIP, the chance of you developing a quote new food allergy should be 0. And to date, that has held true. As I always say, though, there might be some new food out there that we don't know about. And we are still learning. We have patients from every continent, so we are constantly studying these questions. But as of now, that statement absolutely holds true. And we don't see things pop back up. Keep in mind, it's all about having accurate data, continuously checking that data. We do check remission data on an annual basis for the first 5 years. And as long as we see all those things move in the right direction, there are no problems. Great. Thank you very much. Next is Maria.
Hello. I'm Maria. I'm from New York. So my question was basically, I saw you guys are working on building a new clinic in the Bay Area. And so I was wondering if you guys have plans to expand around the country as well.
Short answer is yes. I hope, if you kind of saw the whole presentation here, that it's abundantly clear that building what we're building is not common, and it's certainly not easy, right? So we worked very hard to kind of get to this stage. We also don't want to sacrifice safety, and so safety has to be a top priority. We are opening in August in the San Francisco Bay Area. Very excited about that, and we are looking to expand, obviously within the next year. But details on that are still something we're working on. We want to make sure that it's done correctly. We have a large catchment of patients from the Northeast, so opening up in the Northeast is a different ask than kind of opening up in the Bay Area. We still have a large amount of patients from the Bay Area as well. So the short answer here is yes, we're working on it. But as I tell everyone, if you're really interested in getting your food anaphylaxis treated, start sooner than later, right? The patients in the Bay Area, most of them have already been in the program for a bit. Now they're going to get to do it close to home. And that's the same model that I think works really, really well. All right, next is Elizabeth. Hello. Oh, sorry.
I'm in Maryland, and unfortunately, we just found out about you. My daughter's 18 and going away to college, and she had a classmate she found out at graduation who can now eat Reese's and peanut butter. And of course, my daughter goes anaphylactic with peanuts and nuts. So we'd love to do this. My problem is going away to college. I don't know if this is something that she and we could manage. Are there any kind of shortcuts you take for kids in college? Like, it's going to be very hard for her to prepare 2 things a day. I mean, I could help her, but can you do more gummy forms for a kid who's in college? Or I guess tell me what you think.
Yeah, that's a great question. It's interesting. We have a lot of patients who are in college. I would have to pull the data for you, but certainly it's certainly around 400 patients, something like that, who are in actual, kind of first year to fourth year of undergraduate. We have obviously graduate students, but I don't include that number. And I've been relatively impressed with the vast majority of them. This is a manageable program. I think a lot of it does come down to their own approach and kind of how much they want to do this. Because ultimately, especially if your daughter's allergic to a number of foods, if we can clear a few and kind of get to cross-contamination, let's say within a year or, 14 months, that's a big win, right? Because now, like, college just becomes a lot easier. And so a lot of our college students, I feel like, are trying to get to that place quickly. And then at that stage, we have to have conversations about, like, all right, do you want to, let's kind of take advantage of summer and just kind of crank through a bunch of things in the summer, and then maybe slow it down during the fall semester and come back during Christmas break, things like that. So we're pretty flexible. I'd advise you just to, talk to our enrollment team and get some specifics and have a nice discussion with your daughter about, how much she thinks she can balance things. But I've always been pretty impressed with our college, our patients who are in college.
Okay, thank you.
Yeah, you got it. All right, next is Craig. How you doing, Craig?
There we go. Hey, my wife and son Eddie actually come out on Thursday for his first appointment. Super exciting. He's really, really pumped. So we know he's got some, like, he's off the chart on gluten and then a number of tree nuts, along with like some fun asthma stuff. Are there certain allergens that you see take more time to conquer versus others? Like, I'm guessing the wheat one's probably a little bit of a tricky one, but just curious.
Yeah, it's a great question. The short answer is it's all based on the total number of proteins that we're trying to actually tackle. So the initial work I did here a long time ago, it was abundantly clear that the higher the number of proteins we have to cross-match to induce tolerance and remission, the more work it takes to get an immune system to do that. So number one, top of the list, is unfortunately wheat. But again, it's not that we can't do it, right? We do this on a regular basis, but we have to work with the immune system that is there, and how quickly it adapts and so forth is something we have to initially study and understand. So we do tend to be very conservative with wheat because wheat requires not only more, I'd say, precise cross matching. But as you mentioned, wheat allergy can often induce asthma states and things of that nature. So we have to look at kind of the whole system. But no, super proud. In fact, that remission video you saw, a lot of the kids who were speaking were anaphylactic to wheat. And then when they talk about eating donuts and pizza and all that stuff, they're actually referring to their wheat allergy, which is huge. So every time we get a wheat patient to remission, I particularly feel great about it because that's just a game changer.
Yep. Okay. Thank you. And thank you for all the work you're doing too. It's something that I didn't think was possible now. I thought sometime in my lifetime I'd see it happen for him, but the fact that we get to start tomorrow now is a little overwhelming. So thank you.
We'll get him to the finish line. And I appreciate those comments. As I said earlier, I really believe that we have to shift the standard of care. I mean, the idea that, kids continue to have reactions and they live in avoidance and all of the trauma that comes with it, frankly, it's tough. And so, as you see patients get to remission here and you see them out 5 years and 10 years and beyond, I will always say that I think the kids really enjoy this the most, especially as they finish. The parents still have these memories, which is the hard thing to kind of get over. But, hey, I still think a shift in the standard of care is what we're trying to achieve here. So thank you for those comments. All right. Hi, Kylie. How are you?
Hello, my name is Kaylee. I'm sorry if you hear my baby crying in the background. I tried to move away. I heard about you guys just through word of mouth. I'm in Maryland. Just kind of crazy. People would bring it up to my mom. Hey, I know someone who goes to this allergy institute, and then somebody else. I know someone who goes to this allergy institute. And so I've already spoken to some moms actually from Maryland, and we are flying out this weekend. My son Judah has his first appointment with you guys on Monday. So we are excited. My question is I haven't really gotten to talk to any parents who have toddlers who are in the program. I'm sorry, I'm just going to close my door. And so he's almost 2.5, and he's just had a lot of setbacks, allergies, major eczema, chronic ear infections. And with all of that, he's, I think because he's got all this inflammation in his body, he's just dealt with a lot of delays. So he has speech delays, and he has a lot of eating delays. And so there are times where he just doesn't want to eat at all, which is a concern for me with the program, with doing the challenges, because I've seen like the older kids with like a cup of peanuts, and I'm like, oh my gosh, I can't even get him sometimes to bite into a banana. So how do you navigate that? That's my first question with little ones and little ones who maybe struggle with eating.
No, that's a great question. And again, we have very young patients in this program. I mean, we have 1-year-olds and such. What you're doing right now is exactly what you want to continue to do, which is communicate, right? Let our teams know, hey, he's from an eating standpoint, it's going to be a road. Okay. As soon as you let us know that, we have resources. We have an entire volunteer team of parents who are just amazing. We can hook you up with them. In fact, I totally recommend that. And you can talk to other moms of toddlers who have been there and actually found a way to get through. We have multiple strategies around food as far as how to disguise the food, how to change the vehicles that we're using as far as the foods, and even challenges. If you just give us a heads up, we can modify the appointment times, give you more time, et cetera. We don't want this to be, that kind of pressure situation. But I think the insight to say, hey, this can be a potential problem and bring that up ahead of time is absolutely key. I would say this. I'm trying to think of like some of the worst cases I can remember, where it's like, all right, they just eat nothing. In the end, kids, I have 3 kids. Kids can control 2 things. They can control what they eat, when they eat or what they want to eat, and when they poop. There's like 2 things. And so it is a power play. And ultimately, if we can find enough things to kind of really dissuade it, you will find a way forward. And often it's just experimenting with all different types of ideas. So I'm not too concerned about it, but again, we're here to help.
Okay, great. And then my second question is, he's battled with crazy eczema since 4 months old. And I have just really felt like it's environmental allergy wise that's causing the eczema, just because he's on such a limited diet and he doesn't eat a lot of the time. So I figured that we'd probably going through the SLIP program, but is that something that we could even start from the beginning, or does he have to start the food stuff first?
It depends on his data and what the analytics say and the AI system wants to predict. The short answer is we're going to take care of the eczema as well. We're going to monitor it, and obviously we'll even treat it for you and offer different approaches. Remember, he's kind of in that very important age where his immune system is developing, right? And so we do want it to commit in a certain sequence. And so sometimes we'll start SLIT really early. Sometimes we'll wait 4, 5, 6 months into the program, but that will all be forecasted for you. Okay. But just for everyone else who's listening, we do look at the totality of their allergic conditions. So whether it's asthma, eczema, obviously the food allergies, gut health, things of that nature, we're looking at the whole picture, trying to make sure that everything is in balance. When you have a nicely balanced immune system, you can actually move patients to remission, again, a very predictable way.
Thank you so much, and we're looking forward to coming out.
Okay. No, you're going to have a great time. Thank you. Next is Alexandra. Hello. Alexandra, can you hear us? There you go. We can't hear you, even though you're unmuted, I think.
How about now?
There you go. Okay.
Yes. So my name is Alexandra. I'm in the Bay Area. And my questions are actually very similar to Kaylee's, except my daughter is 8. She's a picky eater. It's hard to get her to eat many things. She also has eczema. And then the third thing that's a little different is that she plays club sports. And so I was wondering if this is compatible with that profile.
Yeah, great question. We have patients who are D1 athletes. We have patients who are in all types of rigorous schedules. Some of them, frankly, amaze me. I don't know how they do that much, work. But the scheduling is something that we, again, what I advise is communication. Let us know, what sports, what's the schedule look like. Remember, we build this all around data science. So the data science allows us to modify things very easily. And we can also make sure that, if a child needs a day off or, a change in schedule, that can also be accommodated. So it doesn't have to be so rigorous in that classical sense. However, we do like people to maintain a reasonably high amount of compliance, because that ultimately does shift the immune system faster. And our job is to get these patients to remission as quickly as possible.
Mm-hmm. And how much time is there for parents to be preparing special foods, like after the gummies?
Honestly, it depends. I would say if it's a patient who's got egg allergy, the egg proteins do take time. Like as far as like a time commitment, at least from our survey data, you're looking at potentially 60 to 70 minutes a week of work on egg preparation. That's the most time consuming as we see. The rest of them are generally about half that time as far as true preparation is concerned. Wheat is in the end of the wheat regimen. It can also be a little bit time consuming, but nothing out of the ordinary.
Yeah, but like peanuts, tree nuts, sesame, those things are
pretty straightforward. Count them out. Yep, pretty easy.
Okay. Thank you.
Okay, thank you. Next is Wintram. How are you?
Hello.
Hi, how are you?
Hi, Doc. Good. How are you doing?
Good, thanks.
I've been listening in, and a lot of my answers have been questioned. I answered through just you guys conversating, so thank you for that. My son, he's 3 years old, and I've known about your program over a year now, and I've been really meaning to go, but kind of hesitant due to his age and how much time commitment and how he can ingest all this during that time. But I think it's doable from what I hear. My question to you today is, I'm in Phoenix, Arizona, by the way, and he goes to Phoenix Children. He sees a GI and allergist there, and our GI doctor wants to do an endoscopy on him before going to your program. I don't know if it's necessary.
That's a good question. I don't want you to disclose health information necessarily, but My advice is honestly call our enrollment team. We actually have an opportunity to speak to one of our clinicians without enrolling, right? You can just, kind of push your case there and have a quick conversation. It's not uncommon if you have somebody who's very allergic, they have, eczema, they have bad food allergies, and especially if they're not having growth the way that we like to see, it's not uncommon for a GI doctor to say, let's just go and do a scope and see. Is it necessary? That's a complicated question because ultimately, what I always tell folks is TIP works really well when you have two things. One is a normal immune system. So that means, we don't want a immune system that has a bunch of autoimmune activity. We don't want an immune system that's not working well. We will test for those things. But if parents know ahead of time that's an issue, that's something we're going to have to work on. So we need a normal immune system and we need normal anatomy, right? Like we need a normal stomach and a normal intestine, normal esophagus. And so if there's any concerns that that's not the case, again, we can manage the patient, but if we can get that data ahead of time, it is helpful.
So maybe it's a good thing. Our GI doctor, he kind of just wanted to weigh out to make sure that he doesn't have EOE, he doesn't have other underlying issue before stepping into the program in case it makes it worse. So I did ask your team, and they had recommended that I go on this call to ask you directly.
Okay.
So
look, I would generally say, look, it's a quick procedure. It's sedation for about 12 to 15 minutes in the hands of a good GI doctor. Phoenix Children's a great hospital. One of my old trainees is a head pulmonologist there, actually. And so, I would say, yeah, probably a good idea to just get it done once, and hopefully it comes back, clear, clean, and
then we're good to go. Because it sounds like in your program, you guys do know if patients have EOE, right, through your testing, or is that through their primary?
Generally, through the testing, we can predict the risk. Like we can kind of get a sense of who's at higher risk. Again, we have so if you take the patients who our system predicts risk for, the number of them who eventually develop EOE is still like 1 in 200. It's not a high number. So I think we're pretty good with our program. Our program is built not to trigger EOE, right? That's our fundamental goal. But remember, if there's a family history of EOE, that really changes things. So you got to look at siblings and parents. If there's a high amount of reflux in the patient, that's so again, we're going to ask those questions. We're going to study that while your child's in the program, and then we will work with your GI doctor hand in hand to make sure things are good.
Okay, and also last question: is it better to start the program the younger they are, or is there a certain age that you recommend, like for them to?
Yeah, I honestly. There's no particular age. I mean, we have a 99% success rate at any age, right? So it doesn't necessarily change things. Is it any faster at a certain age? Again, I'd argue, we can't necessarily make a comparison, right? But like, let's say if you're waited till your child is like 25 years old, maybe you'd have a few less allergies at that age, and maybe that's the way to go. But then you're looking at 2 decades of dealing with food anaphylaxis risk.
Yeah, so. I feel like it's definitely affected like his growth, because he has fallen on the growth chart, and that's how he ended up at Phoenix Children. So after the program, let's say it takes 2-3 years, and then after that, can it like relapse? Can you relapse in allergies, or? No?
It's so if you look at our patients who hit remission, the first year of remission particularly, that's when we're training the immune system in a different way. We will have somewhere about 1 in 100 patients in the first year of remission will have symptoms, and often it's like a hive or something very mild, nothing serious. We do have rarely a more significant symptom, but it's often tied to they didn't do their dosing exactly the way they should have, right? So those are some of the factors at play. Once you move to year 2, that number drops very close to 0, and year 3, it's pretty much 0. So, the further you go into remission and we study what are the remission processes of the immune system, we don't see the patients relapse.
Okay. And do you recommend for patients to come back every X amount of years after we're done with the program to just keep up with the data and make sure everything's good?
Yeah, we recommend once a year visits for 5 years. And then after that, we can space things out.
Even in their growing years, even this young at 3, only 5 years?
Our data is really good. Yeah.
Okay. Okay, that sounds great. Thank you for answering all my questions.
Oh, you're welcome. Thank you.
Thank you.
All right. Next is Angela. Hi, how are you?
Yeah, I'm from my doctor. What's going on?
Oh, so she just maybe is a little too blonde. So is her root color enough to use as a
It is. I
light?
think. Yeah. Oh no. Her low light should do 80.
Hi.
Then it down.
I'm just waiting. Maybe she'll realize she's
Okay. There you go. Go for it.
okay. I'm from Connecticut, and I'm on here regarding my son, who's 14 years old. The question that I have is, I know questions have been asked about eczema. He does have eczema, and we did try he has a peanut and a tree nut allergy. And we did try the traditional peanut desensitization with the powder at a local allergist office here in Connecticut, and he failed that because his eczema kept getting worse. And we're in the Yale medical system here in Connecticut, and that's who we see as a Yale dermatologist and a Yale allergist. And we did all the traditional treatments for his eczema until he basically experienced topical steroid withdrawal. Are you familiar with that?
Yep, absolutely.
So in 2019, he went through red skin syndrome, and it was horrific. And we haven't used any type of steroid since 2019. And I'll say today, he's doing fantastic skin-wise. He still has very mild eczema that we only treat with hypochlorous acid spray, zinc, kind of like natural treatments. And he's doing very well skin-wise. And we had his IgE panel done during topical steroid withdrawal, and as expected, because we also work with Dr. Ian Miles at the NIH, who's currently doing a study on topical steroid withdrawal and some of the immune markers of it. And during TSW, his food allergies skyrocketed. The total IgE was higher. All of the markers for each of the allergies individually was higher. And we just recently redid it, and they all went down significantly. So walnut is his worst, and say it went from 30 down to 2. And so they all went down significantly, which tells me his body is kind of in a much calmer state than it was back then. And so our question individually about doing this program is worried about reactions and how they're treated, because we really don't want to use steroids for any reason unless it was a matter of life or death. We don't want to use them topically, and we really avoid them at all costs. So that's kind of put us a little bit at odds with our traditional doctors, because the standard of care uses that for just about everything. And so that puts us in a unique position in trying to figure out whether we should do this or not, because, what do you do if someone does have a reaction? And, for us, is that worth? Because what we know about steroid withdrawal is that just any exposure to steroid just could kind of cause this whole red skin syndrome thing all over again, which we don't want to do.
Sorry to hear that your son went through this. I think I've seen about a dozen cases of topical steroid withdrawal in my career so far. And I'm sure I'll defer to your dermatology academic colleagues and get their feedback on this. But what I've seen, at least in those cases, is that as they age and as their skin anatomy changes, the concept or the same type of steroid withdrawal it doesn't seem to continue. It's not like a lifelong, situation, which is good. The issue around this type of specific medical condition is largely around the way the skin and particularly the dermis interacts with any antigen. So, it could be an antigen in the gut, it could be an antigen on the skin, it could be an antigen that you inhale. And it creates this type of storm that can really generate lots of false data. So you get a bunch of false positives, some false negatives. It gets to be very, very messy. And yeah, we've had those patients in TIP as well. They've all done really well. Fundamentally, we have to just understand what his data looks like to give you a better answer on his case. It's just hard for without having actual numbers and such to make a general statement. I will say though, we've had, in fact, just recently I saw a kid who was out like 6 years. He had topical steroid. Both parents are physicians, and he's doing great. He's in full remission. And I did ask them, like, hey, has he ever needed a steroid cream for this, that, or the other thing? And he's actually used it for like bug bites and things of that nature. And he's had no issues. And I believe that is a common story as the dermis just changes its anatomy. We can take things as slow as you want. It's just a question about the data and the approach. We are not big fans of Dupixent. It can be utilized, but we have specific concerns about how it affects lymphocyte function and TIP itself. And but again, we'll work with whatever case requires that kind of help.
When he first got off the steroids and he was very bad, this was 2020. We tried Dupixent for 3 months. He experienced sun sensitivity on Dupixent, which we never had ever before that. And at the time, they didn't know anything about that. So they kind of told us, oh, that can't be. But I know now that they know that that's more common. But we actually got off of it because we also got COVID in 2020 and they didn't know what to do. So they told us to get off of it. And at that point, we decided to just handle this a different way. And so he has not had a pharmaceutical since 2020 and he's doing better than ever. So I'm very hesitant. But I am at least relieved that you've heard of TSW because a lot of physicians will still say that, that's not a thing or that it's just severe eczema, and that's not true. And so I'm relieved that you've heard of that. And it sounds like for us, we should just make an appointment and get some personal data.
That's probably the next step. But again, and send in any additional data you have ahead of time. We can look at those reports. If there's ever a biopsy done, that kind of information that would be super helpful.
Okay, thank you.
You're welcome. Thank you. Next is just a few more questions here. You got Sheila.
Hi, I'm in North Carolina, and I have a newly 6-year-old who has a severe wheat allergy. We were thinking he was moving in the right direction, but his wheat unfortunately doubled from 50 to more than 100. And so I just want to know, for a kid like him, where it's very severe, do you have data for kids like that and success? And a little bit also about, you mentioned that you look at some proteins to determine the success. Is that, I think he has never done any sort of component testing, and I don't know if that's maybe something that's not even offered in typical commercial labs, but just trying to understand a little bit of how you determine which kids are going to succeed, and a little bit about how long the program is for a kid like that.
Yeah, it's a great question. I'll just try to give you the short summary on this. Mm-hmm. When I started this work 20 years ago, I knew that the complexity of the immune system is such that we're not going to have single solutions for all patients, right? There was not going to be a single form of treatment for a wheat patient, peanut, whatever. And certainly, that is deemed true, right? I mean, there's the one single form of treatment that was out there was Palforzia for peanut. They attempted it, and it has not done well, fundamentally, because one size doesn't really work for the immune system. So diving into that, I had to design the targets of what we're trying to actually manipulate or try to actually treat. And so we have what we call evolutionary proteins, then we have biosimilar proteins, and then we have immunobiology proteins. So there's actually 3 sets of proteins that we study on every single patient. Every single food protein gets at least 5 different analyte approaches. So we're not using one thing or 2 things to determine what's going on. We're using all of these large databases and then a single angle or a microscope essentially across this, thing of wheat as an example. Wheat has 25 primary proteins. Those proteins are, assessed, across the scale of our testing. They're assessed across biosimilars as well. And with that information, we go ahead and design an actual treatment strategy. That's all done through AI, machine learning, applied math. It's difficult because if you can imagine what we're trying to do, there's 25 proteins that we have to essentially move across. And the goal is to not touch wheat until we're roughly 2/3 the way through all of these proteins. And, some of these classes of proteins, patients have gaps. So like in some cases, we can utilize a certain biosimilar, but their immune system won't adapt to it. So now we have a gap. So now we're taking a larger leap to get them to the next step of kind of tolerance induction, if you will. So these are the complicated aspects of each case. I don't want to dive into too much because it's kind of dense. But fundamentally, that's kind of what we have to do in a case like your son's. The fact that his numbers went up is not uncommon, unfortunately. We need to identify how many biosimilars we can actually work with in his case. Hopefully, he has many, right? The more that we have, the more that we can work with, the more that we can pull down his wheat numbers. And then eventually, when he starts wheat, he can, get to the finish line. And again, when they're done here, they're generally consuming at the end of year 1, they're consuming about 6 grams to 8 grams of wheat protein in one sitting. That's roughly, 2 very large slices of bread, moderate sized plate of pasta, things of that nature. And it's all based on that data science.
Thank you.
You got it. Next up is Kendall.
Hi, good morning. I'm from Arizona. We're actually coming on Monday for my daughter's first appointment. I just had a quick question. Her previous allergist had only tested her for what she's ever had a reaction to. So tree nuts and shellfish, which we know, but do you guys test overall, basically all food allergies, or I just want to be sure that we're getting a comprehensive view of her, because there might be things she's never eaten that she may be allergic to.
Yeah, absolutely. So we test, I can't say for everything, but we do test for a very large panel of commonly consumed foods across the board. I will say there are some atypical things like spices and certain things like that, that we're not going to necessarily go after, because if you can consume certain food proteins, you should be able to consume those safely. So, but again, if you see anything, just report it up to us and we can always add on additional testing if needed.
Okay, perfect. I just wanted to make sure. I mean, we've never done soy, and I don't even know if she's consumed it. I'm not too sure. So I just wanted to see if those things would pop up, if we had an answer. Cool. Thank you very much. I appreciate it.
You got it. See you Monday. Next up is Roxanne.
Hi.
Hello.
I'm Roxanne Christensen. I'm in the New Jersey area. So I have 3 kids, 10, 7, and 3, and they all have multiple food allergies. They all have EpiPens. Unfortunately, they're not all the same allergies, so I'm cooking different meals every day and sending different lunches to school. We are considering doing all 3 at the same time. So I guess my question is, are there families with multiple kids with multiple allergies that do in the program? And also, is it going to be very tedious for me, since I'm preparing most of the meals, to be preparing different gummies and different, allergy trial things at home for the kids?
Yeah. First of all, God bless you. I mean, kids,
it's hard. It's a lot.
That is not easy. I think the record that we have is 5. We have one family with 5 kids who did it simultaneously. We definitely have a lot of, 2 siblings and 3 siblings in the program. Again, happy to connect you with volunteer families who have multiple kids. Again, without knowing the details of the cases, the system will actually try to generate treatment models that will try to line up proteins across the 2 siblings so that it's not as cumbersome. But certainly if they have completely different allergens, then you are kind of running 3 different cases simultaneously. So I guess the data will tell us that, and we can kind of dive into it. As far as the time commitment and so forth, certainly, I'm not going to downplay it. I mean, it is going to be more work when you have 3 kids in the system. But I will also say there's an opposite benefit here. I always find that when there are 2 kids in the program simultaneously, both kids do better. They are just in it together. They are a team. They can kind of, bemoan their complaints when they happen and then, kind of move on. I do think it's actually harder when there's just one kid, not by a lot, but it's hard when, you're alone and you're kind of doing this and your parents are telling you to do the program and do the treatment and nobody understands, right? But having somebody else who understands just makes a big difference.
And will they, sorry, another question. Since we'll be flying out, will they be able to kind of time the appointments so they're all being seen at the same time or testing at the same time?
Absolutely. Everything will be coordinated simultaneously.
Perfect. Thank you so much. I appreciate it.
Thank you. And last question is Julie Ann.
What's the longest that you've had someone in treatment, and how many allergens did they have? Because, like the ones that are the long-termers.
Yeah. The most number of primary allergens I've ever seen was 21 primary allergens. I mean,
Is that including all the nuts?
Well, it certainly includes many different nuts. It was a
Okay.
number of different seeds and some atypical seeds. The list of seeds can get quite long, but it was 21, including wheat, which is a real tough one. And so, yeah, that patient took about 9.5 years to finish the program.
Okay. So wheat is the toughest one, it sounds like. Okay.
It truly depends on what the data looks like.
Okay.
Really, that's a key. So.
All right. So I can talk to an enrollment and say, actually, we can join the program. Let's get going. Okay.
We'll make a note on our side here. Give them a buzz. We'll take care of things.
Thank you.
All right. Mia, any last comments from you?
No, it was great to be a part of this conversation today. And we look forward to seeing some of you guys in clinic, and just really want to be a partner with you on this journey, and want to encourage you as you go into TIP. If there's anything you need, anything you don't feel like is being met, reach out to us. We are here for you, and we want to support you through this. It takes a village, so we definitely are going to be a part of that for you guys throughout your time here.
Awesome. Appreciate the level of commitment. And again, thank you for joining us. We have a webinar every month. If you have additional questions, please reach out to our enrollment team. Again, there's many additional resources they can relay you towards. And I think you would find that the amount of information we provide here across the food anaphylaxis space is quite vast, and probably certainly not something you find in a lot of places. But we look forward to seeing you. This is the standard of care when it comes to food anaphylaxis therapeutics. And we look forward to seeing you. Hopefully you're on site, if not next time. Thank you very much. Have a great day.